from the start, finished school and went through a biomed science degree. That was where my initial sort of cutting the teeth in university. Interested in neuroscience always, which back pain has a very good connection with the neurosciences. So I did my research honours there. So again, it's clearly that in isolation is not addressing what we term the root cause for back pain. And I found, working with yourself and then seeing what the old FMTC over at St Andrews was like, and all the philosophy and concepts behind that really made sense to me.
Thanks very much, Lockie, for coming and having a bit of a chat with me.
Always a pleasure, Dave.
Yeah. We are here at the Functional Movement Training Centre, and I've got Mr. Lachlan Loose, who's one of our valued members here at the Functional Movement Training Centre, delivering the NeuroHAB program for our back pain patients and our neck pain patients. And Lachlan, I reckon you probably treated thousands over the last
hundreds
few
if
years.
not
Yeah,
thousands.
getting close to thousands.
Yep. A lot of the same things, but still get new surprises every time we get a new program coming through.
So as you know, I've talked a lot about the NeuroHAB program and my experiences as a clinician looking after back pain and spine surgery. But I thought it would be a really interesting perspective, and ultimately I'd like to have a bit of a chat with all of our staff members to sort of get their experiences and their knowledge over to the community. So starting with yourself, Lockie, tell us a little bit about your professional background and training, and
Sure.
that sort of led to you working here at FMTC.
Yeah. Well, from the start, finished school and went through a biomed science degree. That was where my initial sort of cutting the teeth in university. Interested in neuroscience always, which back pain has a very good connection with the neurosciences. So I did my research honours there. Between degrees was working. That's actually how we met in an operating theatre context. So I was
you were a
wardsman during that while I was studying physio.
Yeah. So that's quite ironic, seeing us operate on people's bad backs.
Wanting to help those people not have to have those operations, ideally.
Yep. So you've seen that side of spine pain.
Yep.
You've seen lots of spine surgery, and you were studying physiotherapy
at the time, so learning these concepts and then seeing some of the structural intervention put into place, and wanting to understand better what's led to that, because a lot of people think of that as that's like the last port of call and hopefully the last thing they have to do before their backs are improved. But we know from unfortunately from the data that that's not always the last. In fact, often it's not the last port of call. They'll have to continually deal with back pain even after surgery, unfortunately.
Well, if someone gets an operation and they still don't fix the
problem,
they may almost if there's time as time evolves, they will highly likely require a second operation.
Either revision or next level up, next level below. So again, it's clearly that in isolation is not addressing what we term the root cause for back pain. And I found, working with yourself and then seeing what the old FMTC over at St Andrews was like, and all the philosophy and concepts behind that really made sense to me. And during my training, learning what is still considered by a lot of people the standard approach to managing back pain, and how it missed a lot of those key points that I saw in practice getting really good results with people with their back. So you
did a standard physiotherapy degree?
Undergraduate degree. So I did the whole thing, the 4 years.
And what university did you go?
At UQ. They just updated it, so it was an honours. So, finishing as technically an honours program, 4 years still.
Queensland?
Yep. Didn't follow the research stream, had done enough research, so just went straight into the clinical side.
And was there a lot of focus during your training on back pain? Was that a major issue?
Yeah, it was something that it was a big component of it. I mean, of course, it's very broad because you're looking at all fields of physio, all sub areas of physiotherapy. You have to be at least taught it once.
Knees, hips,
shoulders,
yeah.
cardiorespiratory, neurological disorders, things like that. The back pain stuff, I will say though, and experienced this in my final year. This was when the university was going through a lot of at least some revision, some update of the curriculum, particularly with things like chronic back pain and how to manage it, because they're finally acknowledging all of the research, the large overwhelming body of research out there that's saying things like, deep core activation exercises, lying on a bed, ultrasound study looking at transversus abdominis, all of those conventions that we'd been taught and learned how to apply. We were almost taught, forget that, or at least put that at the back of your mind. We need to update the approach to it. Now, not to say that they'd hit all the points, but at least there was some change to how back pain was being viewed and looking at more function rather than individual structural interventions.
So the conventional paradigm, you're saying that we were recognising that they weren't working.
Yeah, that we're not winning a battle. It's if anything, it's growing.
Yeah,
it's a.
And of course, when those new paradigms are implemented, there's still a very significant lag period before it becomes conventional.
That was just my final year of university, for it to then disseminate to the next generation of physiotherapists, let alone the people who make the business decisions or run the departments. For me to reach that point, you're talking 10 years maybe before it's everyone who's in those positions of power and management are even aware of it in some instances, unfortunately. That, hey, the curriculum has been updated. And it's the responsibility of physio, obviously, to keep up to date with best practice and professional development. But even still, those things take a long time before they become widely accepted, especially if they contradict current practice, methodology, which does rely heavily on the direct hands-on intervention of a therapist, your manual therapy type approach
manual therapy,
which is good for business. That's why it's hard to get someone who has used this for a long period of time and to them feels that it's effective to realise that maybe there's a better approach to it.
So a lot of your physiotherapy training would have been requiring you to put a patient onto a couch
to start with, at least,
and deliver manual therapy.
Manual therapy, and it's always the sort of expectations that you help with some acute short-term relief of pain. But the problem is, if that is the only method of intervention you provide to the person, then that's never going to address that root cause problem, and they're going to be reliant on you then, which is not bad for a therapist, but not great for a patient long-term. So giving some symptom relief acutely. We try to provide that just purely with healthy movement within obviously an appropriate level of movement for the individual, whereas a program entirely dependent on passives, recumbent, lying on a couch and having your symptoms relieved is never going to fix it.
So just to paraphrase that for people, to make gains, the patient has to be actively involved in the rehabilitation. A patient is not likely to benefit if the physiotherapist is doing all the work. And you're lying there on a couch.
Receiving
You've got to be involved in the
actively,
rehab.
But they also need the right guidance on that as well. So it's not that patients aren't given exercises in a conventional sense, but that was a big shift in realising that isolation of an individual muscle group in a tedious, boring exercise is not likely to get a good outcome for someone.
So a lot of times, and I make a habit of every single patient that I see asking them, so you've done a lot of physiotherapy, and they will say they've done exercises. And the common exercises will be things like clams, hip thrusts, planking,
and a lot of core strengthening.
Things like that. So in a sense, that's kind of being actively involved. But what are the downfalls of that methodology?
Yeah.
What do you...
We talk about that a lot in our program, and we try to explain that to patients, because when you say, well, we're going to get you moving, their first response often is, well, we have already been doing that for ages. It's not worked.
Yeah.
So the downfalls in that are that the problem arises from the overall environment the body is in when it's moving. So strengthening, for instance, of the core. You could have the strongest core of any athlete, but if you don't know how to utilize that core and move well, that's not going to protect your back. Perfect example of that might be trying to develop a skill like juggling. If you're trying to, well, I want to be a better juggler. Well, you could think of it in a monostructural way. Biceps, they're the prime mover in that. Well, I need to get stronger in my biceps. But if you don't have the skill, you don't have the coordination, the timing, all of that, to just throw and catch a ball, you're never gonna be much of a juggler. And that's the same thing with the core. You could be stronger, but then you go to bend over, brain doesn't know how to coordinate between that and the hip joint, and the knees, and the back, and there's where your problem arises from. That overall dysfunction. And a lot of therapy stops at that monostructural level. They think, well, we've got an improvement here. It's a measurable improvement. You're stronger in your glutes. That was the problem. We'll say that's the problem. Maybe they'll get some short-term relief in their back pain just for being active, and maybe that manual therapy helps them. But then 6 months later, they're back with the same problem or less.
So you may deliver a therapy, or conventionally you may deliver a therapy that makes someone stronger. They may be able to measure better range of motion, which is a common thing where people go, oh, look, you're moving. But you used the example of juggling, and I like that. It's that they may still not be able to juggle.
Exactly.
They are still not skillful.
I'll ask them to pick something up, and even though they have improved a lot of their capacity and in a narrow band, they're no better at doing that and protecting their spine. They might even be able to lift heavier, but they're still doing it in a way that they're susceptible to back injury, or at least exacerbation of pain.
So these are things that are quantitative and measurable, and they are getting better. But the difference being that what you deliver is a qualitative improvement. You're actually making the movement quality better, and we can sort of bring that back to the nervous system and just call it coordination.
Basic motor coordination for really simple innate movement patterns, things that every person should be able to do, and if given the right approach to it, given the right level, will be able to return to border, major structural issues, and that's where you can help them. So if they've got a major structural degeneration that needs repair, that might be the first port of call, but then it's always going to have to be followed up by retraining movement.
Do you think that if you were able to get hold of every person, hypothetically, who had some niggly back pain really early on, and if you improve their movement quality with your skills of training movement as a functional movement therapy, if you were able to get to them, that earlier, you would put me out of business. I would not have any more spine surgery to do.
Well, I think you've already sort of seen some elements of that in your practice, probably fewer patients that result in a surgery because they've been able to avoid that, conservatively manage it. So definitely. And I think the earlier the better. So we traditionally have had a lot of patients who have already been referred to a neurosurgeon, Dr. Johnson, for instance, who come to see us, and that's very late in their journey. But we're seeing more and more people getting referred by GPs, early onset, before it's becoming that chronic stage, and hopefully they'll be able to avoid that chronicity altogether.
I think that's a really key point, is that, you've got to, clearly, if you leave things to the very, final stages of bad movement, the spinal joints will break down. And when spinal joints have broken down to a point that they cannot naturally heal, then of course surgery becomes necessary. But if you as a patient have pain and we implement the right rehabilitation as Lockie's been describing, you can very easily avoid the future need for surgery. It's a little bit like someone who's smoking cigarettes. If you
earlier you stop, the better.
If you've been smoking cigarettes for a year, and then someone says, "Hey, why don't you stop smoking cigarettes? You'll probably be able to avoid the lung transplant later on.
Yep.
It's
never too late at the same time. That
Yeah.
at any point, even if you've been smoking till you're 60,
Yeah.
70, you're still
Yeah.
better off to stop at that point. And
Yeah.
you wouldn't think, all those years I've been doing it, why stop now? No, at any point it's going to improve. You've got better odds if you started earlier. Smoking is another great way to think of it. We use that as an example sometimes, is that everyone knows someone who's been a pack-a-day smoker, or has heard of someone, my grandfather lived to 105 and he smoked a pack a day life. Now, it's possible. Does that mean that's how you would base your life based on that statistic? Well, we know it's statistically that's a rarity. Most people, if they do that, they're going to be a much higher rate of issues. And people's backs are the same. Some people get away with terrible movement for a long time. They might have terrible structural degeneration, and just by genetic or anatomical luck, they don't experience pain.
They're sort of they're
outliers,
fringe, outliers, fringe.
But it's very easy anecdotally to pick that and say, see, why should I do that? And it's like, well, we don't base our lives off those anomalies. We base off what's
and even if you're a smoker and you don't stop smoking and then you get the lung transplant, it makes no sense to continue smoking after your lung transplant.
Absolutely not. Or like a liver transplant. They're not going to give you that liver transplant unless you can show, you've stopped the behavior that's led to it. It's the same with your back. Like any other part of your body, a limp is an example with an ankle injury. It's very easy to recognize the limp. So an average person can spot it from a mile away. We can see, that person's walking with a limp. A limp in the spine takes for most people, it would take a specialty eye for that. You need training to know how to recognize that, because it's not as evident, not as obvious. So people might say, I keep a straight back when I lift, but they'll be missing one component of what is healthy movement, and you need training for that, and that's where we come in, is correcting those patterns that are otherwise you're oblivious to.
So that skill of that eye for movement is not something that is easily acknowledged as a skill that's taught in a conventional physiotherapy program. You've really got to recognise that movement dysfunction exists, and then define in your brain in a very structural and biomechanical way what is good movement. And then once you've understood what good movement is, the next step is, how do I convert that knowledge that I have and make a patient who may have pain, who may be not athletic, make them acquire it as well. So,
and that's a career-long thing, and I'm relatively early in that, but I've put a lot of energy and focus into that. I think during the degree, I'm very happy with the degree for the standard
gives
of
you
sport,
the foundation,
but it just gives you that foundation. You don't spend much time. You're taught the basics. This is what a squat should be. This is what a lift should be, like a deadlift or a lunge, but very little time given to that. I've spent years of my life, decades almost, acquiring the skills and the knowledge and the body awareness for myself, as well as observational, to be able to teach that. And that's taken, so average graduate physiotherapist, probably a little more active maybe than your average university graduate, but doesn't mandate that they have good body awareness or that they've ever seen or taught how to apply these functional patterns of movement. They'll know how to isolate a muscle. They'll know how to cite its origin and insertion, how to get it activated, how to test that muscle. Because that is where a lot of the focus is at university. But beyond that, it's acquired after the fact.
So the take-home message there is being a functional movement therapist and a functional physiotherapist, focusing on movement is a very distinctive skill set. That is, you don't just come out of university with that skill. And you can't just go to the corner store physiotherapist studio and receive that.
No.
And yet it is one of the most important elements that determines joint health.
Absolutely.
Because the primary function of a joint is movement.
It depends on the variety of the movement and how much and how little and range and all that. But essentially, it should be moving.
And our spine is just a whole stack of joints built up on top of each other. Do you think that's why? Do you think that's why movement therapy as a methodology is not widely available? Like, as far as I know, as a clinician, this is the only place in Brisbane that delivers specific and distinctive movement therapy. Is that the barrier? Is that the barrier that the skill set is not?
It's being picked up a lot more. I mean, you can search functional movement now, and compared to 5 years ago, the hit list on Google will be far greater, and you'll see places that will profess that they teach it, and it's really about what that actual definition is, and so you see all sorts of videos on YouTube as well, people doing functional movement, but it's not in essence really that. So standing on a wobble board, bouncing on one foot, eyes closed. That's functional. Well, it's not. It doesn't transfer into the real world, into day-to-day movement. So it seems simple in that regard. A lot of people are surprised at how simple it might be. We're just, I'm just getting you to sit and stand. I'm just getting you to bend over and grab an object. It's not getting caught up in refinement of a single individual detail there. It's that whole compound movement. So most places that I've worked or other therapists I've graduated with, I've talked to about that, they don't have that as part of their typical treatment. It's following the same conventions, good assessment. Maybe they'll isolate some imbalances or muscular weaknesses and then isolate that muscle, get some improved outcome, and then that's the end.
Back to what you said earlier about quantitative versus qualitative. And when patients do
never get taught how to squat, which is just a healthy movement for day activity. Not even, people think, squatting, gym, barbells. No, squatting when you sit and stand from a seat, squatting when you pick up your shoes off the floor, hinging when you reach into a drawer. Those are all things that get missed.
And I've looked up some of those things online about other services that deliver functional, and none of them actually define for me in a clear way what good movement actually is in regards to the lumbo-pelvic spine. Whereas NeuroHAB, within a week or two,
session, we
within
talk
the second
about
session,
definitions
we define it. So
just
briefly talk about the 5 key rules that define good movement patterns for the lumbo-pelvic spine.
I think a lot of why that doesn't get defined is there's a little bit of apathy or therapists not giving people enough credit that they have the ability to learn and apply those skills. Those the 5 key points that we talk about, at least, which they're neutral spine. So adopting a neutral spine whenever practical and whenever able to, using hip-centric rotation, so using the big ball and socket joint of your hip as opposed to excessively loading the knees, for instance, or flexion and extension through the spine. We want to be deloading the knees and engaging in particular with your posterior chain group, which often people miss altogether. I'll just sort of demonstrate the typical squat lift we see. People drop down, stay bolt upright, load their knees, use their quads, and they're not engaged with their hamstrings.
So we would say that's highly dysfunctional.
Dysfunctional pattern of movement.
Whereas that's kind of what's taught. Bend the knees, keep the back straight.
Bend the knees, keep the back straight.
So it's kind of the exact opposite. That's
they'll get 1 or 2 key points, and that's I think what I was trying to say. Where people get apathetic or they just sort of give up on the concept of we can do better. Because it does take a lot of work. It does take concerted effort, and not just in the 2 hours a week that we see our patients. That from day one we say you need to be thinking about this all day, every day, and applying it, not stopping doing what they're doing. And grabbing out a resistance band or lying down, but just when they go to do a daily task, apply it. So 1 or 2 of those key points to us is not enough. You need to be consistent with that. And it looks different when you apply it to, say, a lunge. The body moves in a different way, but you're still adhering to those points. The biomechanics
are still there.
It's still following those fundamentals. Neutral spine, hip-centric rotation, deloaded knees, posterior chain, and proficiency through the full range of movement, not just to a point, which takes time. And that is another element. Some people will come to see us and they're in a bad way, they're very clearly lacking in mobility or body awareness. And that person, it might not be, we have an 8-week program we run, it might be 3 months, it might be 6 months, depending on the individual, where they're at. But you're going to give up on that person. We just scale it appropriately and just try to keep consistent. They've got to put the work into it. It's never going to come to to you without that. Some people it's easier than others, but
and that's a pretty fundamental thing too. Like you get out what you put in.
Yep.
There's no magic potion for resolving 20 years of back pain, but if you start doing the right thing, you can start to make gains and make improvements. And I think we use the word virtuosity. We want to be virtuous. We want to be exceptionally good at the unexceptional. So sitting down in a chair, let's be really good at doing something as simple as that, and that will then relay into lots of other things. And I say to the patients that when you achieve that virtuosity, you're kind of rehabilitating your body every second of every day.
Yeah.
Because every day you're going to get out of bed. Every day you're going to be opening up cupboards. You're going to be sitting down. You're going to be emptying the dishwasher. You're going to be picking things up. So your rehab, you're skilling people to be rehabilitating by themselves at home every day.
Which is the problem. That's the very problem, is that they've lost that virtuosity in their daily activity. So they're not in pain and injured because they're not doing exercises and stopping and doing arbitrary exercises. They're in that state because they're not applying this throughout their day. So that's what we need to target, is their daily activity and appropriate to whatever capacity they're at, obviously, and what their goals are. So we're not expecting every single person to want to be athletes in that sense, like where they're coming to a gym, but be athletic in their patterns of movement in their daily activity. The other big thing I think is a lot more palatable to people to think, well, I don't have to allocate any extra time in my day. Although when we get people to practice stuff, we try to limit it to maybe 10 minutes a day. But
just to reinforce the motor pattern.
Yeah, exactly. To start the day with maybe some practicing of that basic hip hinging pattern, bit of mobility through the shoulder girdle, and then go about your day. And keep virtuously the whole way through. And that's the biggest thing the first week, is people start to really bring awareness to how many opportunities they have. Even in a sedentary type job where they're seated for most of the day, they still had to get to work. They still had to
get in the car.
Get in the car, go to the back and forth from the desk to the cooler, to the break room. End of the day, they're picking up after kids or looking after pets.
If you're alive, you're moving, and you may as well move well.
Exactly.
May as well move well. And I see patients when they've completed the program and they come back to see me for a checkup, every single one of them just says, my God, I did not realise how much I didn't know about simple moving
daily
in life. And of
Yeah,
course...
when you haven't thought about it ever, really. Except for when maybe you were learning how to walk, and even you don't obviously recall that. But that's when I talk about innate patterns of movement. It's a very popular in OH&S programming and teaching of maybe work safety training, to use the example of an infant learning how to bend and lift. I say learning, no one's there teaching them how to do this,
they
right? They
do
just
it
naturally do it. And and you look at them, they do beautiful little deadlifts or squat lifts, and they might be a little bit wobbly and a little bit floppy, but the basic pattern is there. No one taught them that.
So those motor patterns that you're teaching here are kind of in the DNA.
They're somewhere.
They're in the coding of
We've just got to reaccess it.
And why do you think that so many people, well, we know that back pain is a huge problem in society. It's one of the leading causes of disability in the world.
Top two.
Why do you think so many people move so poorly? What's the root cause of that?
When you think about what we do in our daily lives, most people in the Western world, compared to the bulk of our evolution as a species, we're talking hundreds of thousands of years worth of evolution versus a few hundred years of industrialization. That has shifted from largely labor or manual type work to, first of all, schooling, which starts at a young age now, sedentary from a young age, seated at desks 6 to 8 hours a day, which, hey, look, it's part of the human experience at the moment, but you lose those basic patterns as you're in that key period of development from age 5 to 18, where their bodies are growing, limbs are lengthening, muscles are developing, but those basic patterns of movement are not being exposed enough. And yes, they might be athletic children and they might be running around and playing sport, but they're still spending 6 hours a day seated at a desk, and they're not constantly applying that movement throughout the day. And they might be very athletic and sporty, but they're still missing those basic things like, how do I bend over and pick up my gym clothes off the floor, you know? And you do that enough times, hundreds of times a day, maybe they'll be fine. Maybe they'll injure their back, and then what was already accelerating degeneration in their back has a sudden instance of injury. And we've had like teenagers, see yourself, you know, they've had an injury and now it's in a terrible, terrible state because what should have healed in a healthy environment is being constantly exposed to a terrible postural sort of approach to lifting.
Pre-existing motor patterns have just been...
They're just still there, but now they're making something that was already not great infinitely worse.
So what you're saying then, just to paraphrase it, is modern society, living in a modern first world country, actively suppresses good motor patterns that we had when we were born.
Absolutely.
If we're born and we go and live in the jungle, we probably would continue to move well our whole life.
It's like an animal put into captivity in a way. You know, they learn those basic, they lose those basic instinctual things. You put them back into the wild, they won't make it.
They forget how to hunt.
And you don't see animals in the wild not knowing how to hunt or how to, because they don't live.
It's in their DNA.
We fortunately, even if you do have a bad back and you aren't able to do everything you would need to normally survive, well, you've got the whole society there to support you.
We're kind of like an animal in a domestic cage, and modern humans have built the domestic cage around
themselves.
And it explains why that musculoskeletal disability is so prevalent in the community, and why we have an opioid crisis, because of course no one wants to have pain, so they then resort to the pain medication.
It's the solution. Do I have to do anything? Just eat this tablet. Okay,
and it
that works for me. Yeah.
So they start off with Panadol, and then they go to Nurofen, and then they go to Panadine Fort, and then they go to Endo.
Symptom management.
And next minute we have an opioid crisis. And then all of a sudden the medical industry says, oh, we've got an opioid crisis. We can't give people opioids now. And now they're in trouble.
From knee-jerk reaction,
no more opioids for you. Live with your pain. Yeah. That's a horrible situation.
And you know, you can think of someone in that instance who's already in, at least patients that come to see us all the time, in a very terrible state, mentally depressed, sometimes even suicidal ideologies, because they've just run out of options. They can't see anything improving their back, and they've tried lots of things, and it's just always missed that key root cause. They're just treating symptoms after symptoms after symptoms.
No doubt. If you are living in chronic pain, it's going to make you depressed. It's going to make you anxious. It's going to create a whole heap of mental health disturbances.
I get depressed when I can't work out. I mean, that's a pipe dream for a lot of these people. They can't even function just to go to work.
But the sad thing about it is when you get that mental health overlay, the industry starts to blame the mental health issues as the cause for the pain.
And again,
it's the exact opposite.
Downstream, it's as a result of a loss of quality of life. They are depressed. Maybe there was some pre-existing mental health,
but it's completely amplified.
Compounded.
And again, you can't just treat the pain by treating the depression. No, you've still got to treat.
They've still got to move well. Otherwise, they're going to cause the back pain, and that's going to make them depressed again. And otherwise, and that's where you get to the other extreme of managing depression and mental health disorders, where there becomes a reliance on sedation and medication and mood stabilization, that those things are in place, to help people ideally get back into normal function. But if you don't restore that normal function, they'll always be dependent on those interventions. I don't want to weigh too much into that.
There's a heap of education in NeuroHAB. It's not just, there's just and that's why the program is 8 weeks and 2 times a week, which is 16 hours of training. It's a big commitment, but it's, I think, my feeling is there is no other service really that delivers that comprehensive, distinctive method that focuses on movement and the education around the movement.
To discuss concepts like pain, chronic pain science, pillars of health, things that not just movement that contribute to it as well. So we do talk about things like stress and mental health and things like that. So
thank you so much for that, Loggie.
Pleasure, Dave.
Just as a little bit of a side, I'm going to try to always end with a little bit of Lockie trivia, just to lighten the mood after talking about pain for the last 20 minutes. So,
serious stuff.
everyone likes to know, I think you must form pretty good bonds with your patients after.
Often, yeah.
Yeah, so if you do the NeuroHAB program, you'll get to know Lockie really well and the other coaches. So
some interesting.
these are kind of yes or no, or they, just quick fire answers.
Yeah,
All right, favourite sport?
Rugby.
McDonald's or Hungry Jack's?
Hungry Jack's.
Vanilla
That's
or
good.
chocolate milkshake?
Chocolate.
Are you a cat person or dog person?
Dog person.
Do you read books or listen to Audible?
Read books, neither. Read books.
Okay. And are you watching any TV series at the moment? Streaming, binging?
Oh,
Favorite recent
binging recently. Oh, look, I liked The Mandalorian. That was pretty good.
The Mandalorian?
Watched it recently, the Disney one. Yeah,
Disney?
yeah.
Okay, Lockie's got Disney Channel.
Yeah.
Disney
Channel, yeah.
Are you a chef or a cleaner upper?
Oh, chef.
Prefer to do the cooking?
The chef. Yeah.
Okay, I'm a clean up guy.
That works as balance. Yeah.
And winter or summer?
Winter.
Winter.
Look at the sweaty mess at the moment. Yeah.
All right. Well, thanks for your time, Lockie.
Pleasure, Dave.
More work to do
chatting to
today, and that's hopefully provided a little bit of insight. We're just skating along the surface of this paradigm and the science related to movement therapy.
What we do.
So there's heaps of information that every single patient who has pain can gain from NeuroHAB. And one of the key messages is don't leave it too late, because obviously then the later you leave it, the harder it is for Lockie to fix up. And then if you leave it really late, then I have to come in and get involved as a surgeon. And like I said, my goal is to actually put spinal surgeons out of business.
Yeah.
I want to put myself out of business so that I
Early
no longer.
retirement, Dave,
Yeah, I'll be retired by then. So, all right.
Thanks.
Talk to you next time. Thank
Thanks,
you.
guys.
Cool, man.
Sweet, yeah, it was good.
Easy peasy. One shot.
One take, yeah.